This is a continuation of our tutorial on investigating conventional irrigation and instrumentation cases. This is Pushpaks case number 2. It was a lower second molar. The radiographs suggest the presence of a radiolucency. Cone beam images were not provided, unfortunately. If you're examining the high resolution images as suggested in the MIE Google Group Drive, the case number is 586. When you go to the SEM folder in the case number 586, you'll have access to all the high-res images from all the different areas of the case. Pushpak's diagnosis page indicates there's a diffuse radiolucency with no occlusion on the tooth. The multi-tooth testing form doesn't indicate much testing, but the diagnosis was necrotic pulp, acute apical abscess. When you look at his case summary, the pulp was necrotic upon entry in all canals. The master apical files were 25, 20, and 25 with a VT taper of a 0.06 apparently, although it's difficult to tell. The irrigation used was sodium hypochlorite, EDTA, and chlorhexidine, and calcium hydroxide was placed as an interim medicament. The case was started at the end of November 2022 and seen again 2 weeks later with further debridement and similar irrigation and calcium hydroxide application. The patient was seen again at the end of December. The medical history now states the patient is having radiation treatment for breast cancer, has had joint replacement, and is taking meds for high blood pressure, hot flashes, and bisphosphonates for osteoporosis. At this visit, the tooth was debrided again with the same irrigation protocol. At the end of January 2023, the patient stated the tooth was still having discomfort and the tooth was extracted and sent to me. This is how I received the tooth and my radiograph of the extracted tooth. This is an occlusal view of the tooth showing the stepped axis and an apparent mesial distal crown fracture. We did get a fairly decent mesial root sagittal section, revealing an apparent common terminus for the mesiobuccal and mesiolingual canals. The distal sagittal section reveals a very broad coronal pulpal area, as suggested by the pre-op radiograph, and a single terminus. Going to the coronal area of the mesial root, you see a relatively clean canal with minimal instrumentation debris. You cannot make much of any dental tubule anatomy, although under the debris lays the mineralization front and it is readily discernible. In most areas in this section, there is little indication of bacterial morphotypes. If there is calcium hydroxide residue, it is difficult to distinguish this from demineralized predentin, demineralized smear layer, or instrumentation debris. When you can examine the dental tubules, it is clear not enough demineralization has taken place to discern the collagenous nature of the intertubular dentin. My suspicion is that the peritubular dentin is still present and has not been demineralized. This is another coronal area closer to where the fracture was. And when you go into that, you can see kind of the remnants of some of the predentin and a much better look at the dentinal tubules. In many cases we have seen, these areas are where the instrument never touched the dentin, which is why there is no smear layer. And then when you go in closely and look very closely, you can see microorganisms pretty much everywhere in the predentin debris, and some actually going down into the tubules. Now, when you look at the midroot area, near where the two canals meet, which is further away from the crown fracture, you actually get a much cleaner appearance. Here, perhaps, is an area where you can see where there's a smear layer next to an area where there are naked dentinal tubules, perhaps indicating where the instrument touched and where it didn't. This view shows the classic smear layer created by instrumentation, and it has not been very demineralized. So this is the classic mineralized smear layer with very little suggestion of bacterial morphotypes. When you go into the distal root in the coronal area, again, where the fracture was, and you look carefully there, you get a very different picture. and many, many more microorganism morphotypes are present. And if you spend some time going through these sections, you'll see the peritubular dentin and the odontoblastic processes, as well as many bacterial morphotypes that are present in the predentin and instrumentation debris. When you go down to the apical area in the distal root, again, you see a lot of debris and more of a classic appearance of the mineralization front. And I was not able to really detect any overt bacterial morphotypes or exposed dentinal tubules. I suggest there is minimal demineralization that has taken place here. This was kind of interesting. In the distal coronal area, where you can examine a tangential cut of the tubules, you can actually see the mineralized non-collagenous proteins, either of the peritubular dentin or of the laminolimitans. I can't recall ever seeing any of this in the dental literature quite this clearly. And I did take the opportunity to just actually section the crown and maybe get a straight-on view of the dentin with the fracture lines. So I thought you might be interested in kind of seeing what an in vivo biofilm looks like along a fracture line. And no matter where you look on that fracture line, this is just one area. You can see that it's just a very robust, thick bacterial biofilm that's present. So that's the second conventional irrigation case. I hope this has helped you identify some of the things you can have confidence in. And next, we're going to look at some laser and gentle wave cases using this background as an aid.